who's just joined us, please feel free your name and where you work in the chat. Thank you so much to everyone who already has. And thank you for joining us today. I'd also like to county partners at St. Mary's County Health Department. We were happy to collaborate them on this training. And for anyone who is new with Max, I'll give a brief overview with the next slide.
Oh, sorry. Hold on 1 second. I'm closing some things out. Okay.
Thank you. So we are the Maryland Addiction Consultation Service. So we are a free support, and we support prescribers throughout the state of Maryland with their practices and addressing the needs of their patients with substance use disorders and chronic pain management. Again, all of our services are free, and that includes our phone consultation. So if you have any clinical questions about a patient that you're working with, you can call and speak with one of the experts on our team, and they will provide you with guidance on how to treat that patient. We also offer education and training opportunities like today's webinar, as well as assistance with addiction and behavioral health resources and referrals. We also have started offering technical assistance. So with any practices that are either implementing or expanding office-based services, we are here to help you get started with that. And we also have our Max Teleecho clinics as well. And that is a collaborative medical education through didactic presentations and case-based learning. Last but not least, happy to introduce our presenter today. We have Dr. Bethany DePaula, who is our Max consultant presenting. And Dr. DePaula is the director of the University of Maryland Psychiatric Pharmacy Residency Program. She is a board-certified psychiatric pharmacist with inpatient and outpatient psychiatric substance abuse practices. We're happy to have her presenting today.
Thank you very much. And I wanted to start off with just a little audience question. So if you wouldn't mind typing this into the chat, I'd like to know if when discussing a patient with a substance use disorder, you've ever heard any of these terms. Just write them in: drug addict or addict, substance abuser, clean or dirty, or medication-assisted treatment. So if you just take a second and chat, put in the chat any of those terms that you may have heard over time.
I'm seeing a lot of everyone's heard all of them.
Yep. Okay. All right. That's interesting. We're going to chat about that. So at the end of this presentation, I hope that you will be able to describe the extent of the opioid crisis in the U.S., identify stigmatizing language commonly associated with opioid use disorder, determine person-first alternatives, and propose scenarios where reducing stigma might improve outcomes for patients with opioid use disorder. So let's talk a little bit about where we are and how we got here as far as the opioid crisis goes. And I'm guessing for most of the viewers today, this is probably not going to be a surprise, but we're experiencing a pretty significant opioid crisis that has been going on for a while. If you look back into the 1990s, and I was a practicing pharmacist then, so maybe I date myself a little bit. There was a big movement in the 1990s to recognize and treat pain. And on its own, that type of effort is great. I do think that we should assess and manage pain. But unfortunately, one of the factors, and I don't want to oversimplify how we got to where we are today, but one of the factors in where we are has to do with this assessment of pain and a real pressure to address pain. If you remember Joint Commission coming in to survey hospitals, it was one of the vital signs, and the main treatment became management with opioids, both for acute and chronic pain. And I have another slide, which I'm not showing today, that looks at sales, pharmaceutical sales of opioids and overdose-related deaths, and there is a clear relationship. As the sales went up, deaths went up as well, and the pharmaceutical companies really identified a niche and began developing products that were long-acting, that were higher potency, marketing those products, and so we had this push in prescribing from a lot of different levels. Around early in the first decade, 2005 or so, there was a recognition that we were in trouble, that there was really a big increase in overdose-related deaths, and a look at prescribing and an effort to re-educate prescribers. And I'm going to show some curves that represent this, but basically you start to see a drop in prescription overdose-related deaths at the point that there were efforts to change prescribing practices. Unfortunately, what happened to a certain extent is that there wasn't great management of opioid use disorder, and so individuals that were obtaining prescriptions through physicians, multiple physicians, etc., when that became hard, just moved to the streets and began purchasing heroin in the streets. And so there's a rise in heroin-related deaths right around when this started to occur, about 2010. And then within a couple years of that, we see an increase in fentanyl and synthetic opioid deaths. And a lot of times fentanyl is available as a prescription, and people think of the overdose-related deaths as part of the fentanyl prescription, but really people are not, for the most part, overdosing on fentanyl patches. They were synthesizing. It's very easy to chemically synthesize fentanyl, and it's cheaper in a lot of cases. And so fentanyl has been mixed in with heroin, it's been mixed with cocaine and other substances, and people don't really know when they're buying these products on the street what they're overdosing. But we do know that as more and more fentanyl was available, there's been an increase in overdose-related deaths due to fentanyl. So as I promised, these are the curves that go along with what I just described. And so the purple curve is the commonly prescribed opioids, and you can see this starts at 1999, that purple curve was going up for a while, starts to level off as we're making interventions about education and recognizing the issues that we're having. So you see that level off occurring 2007, and then actually a drop in commonly prescribed overdose-related deaths. About the point that things are starting to level off, you see the yellow-orange line, which is heroin, taking off and then sort of leveling off. And then the black line, which is fentanyl and synthetic opioids in general, is taking off and continuing to rise. If you're wondering how Maryland falls into all of this, it's a fairly similar pattern. I will tell you that I remember learning in pharmacy school that Baltimore City, at one point, I don't know if it still is, but at one point was the heroin capital of the country. So Baltimore City has had an ongoing issue with heroin that predates some of what I'm talking about. But if you look at Maryland as a state, the data is very representative of what's going on a national level. So this is just data from 2007 to 2018, but you can see that orangish line is the prescription opioids, and that at that point, prescription opioid overdose-related deaths have sort of leveled off. Meanwhile, our blue heroin line was taking off and then dropping, and the green fentanyl line was, as heroin was starting to drop off, increasing. So very similar to what you're seeing on a national level. And this is a little bit of foreshadowing to what I'm going to talk about in a few minutes. But when you look at opioid-related fatalities alone and you compare Q1, well, first of all, if you look at them across the board, you can see that they were starting to level off and even drop a little bit between 18 and 19. But when you look at Q1 of 2019 and compare that with Q1 of 2020, we see a jump again. I did want to talk a minute about opioid use disorder and incidence data related to opioid use disorder. And we know this is data from the National Survey of Drug Use and Health, which this is 2019 data that was published in 2020. At that point, there were 1.6 million individuals ages 12 or over who met the criteria for opioid use disorder, and particularly concerning 21.6 million individuals 12 or over who needed substance use treatment, with about 4.2 million receiving any substance use treatment. So we know we have a long way to go between what our needs are and what we're providing for our patient population. And things are unfortunately not getting better, and that's what I was sort of foreshadowing, which is when we think about the intersection between COVID and opioid use disorder, the short of it is it's not good news. So we have statistics from CDC's National Center for Health. There were 75,500 overdose-related deaths occurring between March of 2019 and March of 2020, which was a 10% increase. There were 81,230 overdose deaths occurring just between March and May of 2020, with the largest spike being after the COVID-19 health emergency. And we know that most states have experienced increased overdose deaths in the first quarter of 2020 compared with 2019, with 7 states and the District of Columbia seeing increases from anywhere from 25 to 50% when you look at data from March to May. Because of all of this, in January of 2021, so hot off the presses, the Health Alert Network issued an advisory which stated that overdose-related deaths are actually at the highest rates they ever recorded in a 12-month period. So like I said, this has really become a very significant issue, and the pandemic has certainly disrupted treatment service delivery and access to care. We have treatment programs that have limited hours. Some of them have had periods where they've closed. We had 12-step where for a while it was hard to access 12-step. A lot of them have moved to virtual, but the virtual format isn't always great for everybody. So this is really an ongoing issue for us. So I think I've stated the case, and you probably were already aware that this is a really big ongoing issue, the opioid use disorder, and stigma plays a big role in why we are where we are and limits our progress in managing these patients. And that's what I really want to focus on for the rest of this presentation. So I'm going to start off. This is National Institute of Drug Abuse's definition for stigma. I just want to make sure we're all on the same page. Stigma is defined as a label with an associated stereotype that elicits a negative response. So for patients with substance use disorder, some of the commonly held stigma is basically that these patients are dangerous, they're unpredictable, they can't take care of themselves, and probably the most damaging, that they cause the condition, that it's their fault, and they could stop at will, they're choosing not to stop. There are various types of stigma. I wanted to kind of go over each one, just a little definition for each of them. So the first is public stigma. And public stigma is driven by those stereotypes, like this patient population is dangerous, and it translates into negative attitudes about them. Anticipated stigma is something that the individual who is stigmatized holds. So it's where a patient with opioid use disorder is aware that there are negative attitudes towards them, and they develop the expectation of being rejected. So if people think that you're dangerous or that it's your fault, you assume that you're going to be rejected. internalized or self-stigma is a step even further, and it's where the individual, in this case the patient with opioid use disorder, accepts that status as valid. So they assume that some of those negative attitudes are actually true about themselves. Courtesy stigma is more of a family or friend experience, and it's where friends and family feel stigmatized because of their affiliation with individuals with opioid use disorder. And then on a more societal level, we see enacted and structural. So enacted stigma is where the behavioral manifestations of the public occur because of those stereotypes. So again, because the public sees these individuals as being dangerous, as not responding well to treatment, they may discriminate, they may want social distance, and enacted stigma leads to suboptimal care and affects access to treatment. And then structural stigma is the totality of ways in which stigma affects society. And so this may be basically stigma encoded in our cultural norms, laws, institutional policies. If you think again about the stigma of being dangerous or violent, that leads to our war on drugs, our emphasis on penalizing and punishing versus managing from a treatment perspective. So the bottom line is that there are various types of stigma. They're all interrelated and reinforcing, and you could kind of see that as I was explaining some of the types of stigma, and ultimately they result in poorer health outcomes for patients. So why are patients with substance use disorder stigmatized? And there's actually been a really great movement to stand up to stigma, especially with mental illness in general. If you think about in the fall, there was a big push in the media with Prince Harry and Prince William, where particularly Prince Harry talked about a lot of the problems that he had with depression and anxiety after the death of his mother, Princess Diana, and how he sought treatment. And having public figures come out and talk about their struggles with mental illness and also what they've done to be successful and to treat them is really beneficial in addressing stigma. And we have seen improvements in depression and anxiety. Actually, one of these pictures here is me at a conference that I went to. I go to a psychiatric pharmacy conference, unfortunately not last year, but usually on an annual basis. And 2 years ago, they had a big pledge to fight stigma type initiative, and they had us take a picture with the sign and sign the sign and post on social media. So that's another example of where there's a movement towards trying to address stigma. Unfortunately, substance use disorders really lags behind. And one of the reasons why that may be is that belief that addiction is a moral failing. It's the person's fault. And so compared to other psychiatric disorders, patients with substance use disorders really get blamed for their disorder. And this can really affect individuals' willingness to seek treatment and how well they do in treatment. When they've done surveys of patients with substance use disorders, many of them report experiencing stigma during treatment in some aspect. So how big of a problem, how pervasive is this? And I wanted to start with the media because this is really one of the big areas that shape public opinion. And so I just Googled headlines from 2020 and these popped up. I have one from the New York Post: apparent junkies turn a stretch in New York City's Midtown into a shooting gallery. Boston Herald: addicts at high risk of contracting the coronavirus. And then ABC News: to some, Maddie was just a junkie. Obituary gives new take on drug addiction. So you can see how stigma is really pervasive in the media. And we know that the public, there's a high rate of stigma among the public, probably to a certain extent perpetuated by the media. But it's also an issue with healthcare professionals. And so these are two surveys that actually are surveys of physicians. The first was done in 2017, and they surveyed physicians that practice in family practice, internal medicine, and pediatrics. And they were getting their attitudes as far as they're surveying them about their attitudes towards individuals who are addicted specifically to prescription pain medications. And they asked them some social distance survey questions, which is this section on beliefs about population. And I just pulled a couple out. But when they asked about people addicted to prescription medication are more dangerous than the general public, 66% of the physicians surveyed endorsed this statement. So again, you see that stigma about this patient population being dangerous. And then landlords should be allowed to deny housing to a person addicted to a prescription pain medication, and 37% of physicians endorsed this particular statement. So a societal effect because of stigma. Then they looked at perceptions of effectiveness of opioid addiction treatment options, and they asked most people addicted to prescription pain medication with treatment get well and return to productive lives. And I'm glad to see that it was a majority, but it was 69% that endorsed this particular statement. I'd really like to see that closer to 100%, considering we have evidence-based medication and non-pharmacologic treatment to manage this patient population. And then they also asked effective treatment options are available to help people who are addicted, and 57.8% endorsed that particular statement. So again, there's been a push for education around stigma, and there was a second survey that was published in 2020, so a little more recent. And again, they were surveying physicians who practice in family medicine, general medicine, internal medicine. And I've pulled out, again, the perceived effectiveness of medication for opioid use disorder. And when they asked about treatment of OUD is more effective with medication than without, again, pretty similar numbers to the previous survey, about 67% endorsed. And then persons can safely use medication in the long term to help them manage their opioid use disorder. Again, 63% endorsed. So we really haven't seen a whole lot of improvement in accepting evidence-based management for our patient population. So what about our substance abuse treatment programs? And unfortunately, we actually also have an issue there. And this comes from the New York Times, but I think it's an interesting statement from an article that was called Wrong Way to Treat Opioid Addiction. The author says most programs view medication as a crutch for short-term use and provide only talk therapies. This widespread rejection of proven addiction medicine is the single biggest obstacle to ending the overdose epidemic. Funding isn't the barrier. I definitely think funding plays a big role too, but stigma is pervasive in some of our treatment programs and in our 12-step. I practice in Baltimore City, and I can think of two specific programs that are great programs and offer treatment, they offer housing, but they won't allow patients in those programs to use evidence-based opioid agonist therapy like buprenorphine or methadone. And I've had patients that have had to make choices with 12-step where they are having a great experience and receiving a lot of support, peer support in the 12-step program, but they have to lead almost secret lives because in some programs they don't accept patients that are managed on methadone or buprenorphine, or I've even heard patients where it's considered any psychoactive medication. So in some cases, they may even be encouraged to discontinue their antidepressants, their antipsychotics. All this stigma really can cause pretty significant negative effects for a patient with substance use disorders. And I want to talk about a couple. First of all, it causes social isolation. That's that anticipated stigma. And so you see a situation where individuals will use in solitary situations. They won't want to tell friends and family. And I think we all know that when we educate about opioid overdose and preventing and managing overdose, that part of that process is that if somebody does overdose, that they're administered as a bystander administers naloxone, that you call for medical assistance. And when people use by themselves, it really increases the risk for overdose. And that's certainly exacerbated in the time of COVID, where we're all really isolated. And then you have family and public desire to social distance, which again is our enacted stigma. And so patients don't have the same support systems that they would have with other disorders that are less stigmatized. Then I've already mentioned that patients may be less willing to seek or engage in treatment. And I can think of a couple of scenarios that I know about personally. One is reduction in treatment retention. And so we know we don't have as clear data with opioid use disorder, but we know with other highly stigmatized disorders like HIV that you can see reduction in treatment retention because of the stigma around the disorder. So there's some extrapolation and assumption that that's probably the case. Certainly there is concern that when patients are on methadone, for instance, they may not want to be on methadone, or they may avoid being on methadone because of some of the negative connotations and stigma associated with that. Stigma can affect how providers perceive patients and can impact their care. And one example that unfortunately I hear about a lot is patients that get dismissed because of their opioid use disorder. So situations where somebody might go to the emergency room, they might have a history of opioid use disorder, but they've experienced acute trauma, they have an infection, and they are sent home, or they're not managed the same way. They're not given pain medications because of that history of opioid use disorder. Stigma certainly serves as a barrier in using evidence-based medications. And I've given some examples of treatment situations where providers or treatment systems may not want to prescribe evidence-based medications. And then even reluctance to make overdose treatments routinely available. For about 4 years, I taught the overdose response program at the Howard County Health Department, and a lot of the individuals that attended that program were employees for Howard County. We also had community members that would attend, but a lot of them, like I said, would be park rangers, or different departments would bring their staff in. And repeatedly, I would get questions from Howard County staff about the fact that making naloxone available, didn't that increase the risk for overdose, because there was this ongoing stigma and, I guess, misinformation that if patients had naloxone available, they were more likely to use opioids because they knew that they could be saved, and that we were actually making the problem worse. And I would always tell people that there's some really great data when you look at some of the early adopters of bystander training in the community, and that data shows that having naloxone readily available reduces morbidity and mortality associated with overdose, but there's no data to suggest that there was an increase in incidence or opioid use just because naloxone was available. But these sort of misinterpretations and stigma really influence provider perceptions. From a societal level, stigma contributes to underinvestment in addiction and the infrastructure. It results in discrimination with insurance benefits, employment, housing. I gave some examples from the physician survey about attitudes about housing for this patient population, and there's been some legislative movement towards improving insurance benefits and correcting parity with the Affordable Care Act to to ensure that insurance companies cover substance use disorder treatment. However, they did a study in 2017 after some of the legislation was approved, and they found that over 50% of states offering ACA plans did not comply with the coverage of substance use disorder benefits, even though it was a requirement. So we do have a long way to go, I think, with insurance. And then stigma clearly affects public opinion and moves to that societal punitive versus health-oriented management. And if you look at how we manage individuals who are arrested because of opioid use and have opioid use disorder, a lot of the criminal system has very little treatment. There's often no emphasis on medications, even if they do offer some sort of counseling. And so what happens is that individuals are incarcerated, they're released with no new skills to the environment they were in previously, and they relapse, and they're actually at increased risk for overdose because where they had some degree of tolerance to opioids before they were incarcerated, now they've gone through a period without opioids, and so that puts them at increased risk. And we're really missing a great opportunity to provide treatment and change the trajectory for this patient population. And then, as I'd sort of presented with those headlines, media representation adds to public stigma, especially around fear. If you think of it, bleeding, accidents, catastrophes, that's what sells the news, and that's what you often see when there are stories about patients with opioid use disorder, and that just perpetuates the violence and the stigma that this patient population, it's their fault, they're dangerous and difficult in society. So I presented all this negativity, and the question is, what as providers can we do to make a difference? And I do think that there is a great role for us to make a difference, and a lot of these strategies are relatively simple. So the first is, you're here today. Awareness of stigma is so important, and talking about it and being aware of some of these issues we're talking about can really make a big difference. So that's step one. And then also being knowledgeable about stigma and specifically about resources that are available that we can share with patients. And I'm going to provide a little more information about that in a few slides. We want to be as patient-centered as possible for this patient population. So we want to use person-first, recovery-oriented language and be really familiar with negative stereotypes, slang, some of those terms that it seemed like everybody had already heard: drug addict, dirty, clean. A lot of those are slang terms that we really need to consider in our everyday language. We certainly want to listen to patients without judgment and treat everyone with dignity and respect is very important. As providers, we need to understand that opioid use disorder is a chronic relapsing brain disease, and as such, we want to use appropriate medical language with both our patients and with our colleagues. And we ultimately want to understand that susceptibility is affected by a host of factors: genetic, developmental, etc., but it's outside the individual's control. It's not their fault. We want to assess patients on a regular basis using objective criteria for opioid use disorder, such as what's defined in the DSM-5. And we want to prescribe evidence-based medications when warranted. And an important point about that is that we need to think about treatment as a whole for the patient and all the treatment that they may be getting, and that the treatment that they're getting is supportive of what we're recommending as a whole. So if we're recommending local substance use disorder programs or 12-step, knowing that those programs are supportive of all evidence-based treatment and using those types of programs for referral are really important, because that helps to ensure that our entire treatment plan can be carried out. Another sort of common stigma around management of opioid use disorder is that there is a limit to treatment, that there is a specific duration of treatment, particularly medication treatment. So treatment with buprenorphine, treatment with methadone. Patients need to be tapered in 6 months or a year. And the reality is that the duration of treatment needs to be patient specific. There's no single duration. So that means that there may be some patients who, just like with other chronic diseases, you think about hypertension, for instance, there are some patients that with diet and exercise over time may not need the same pharmacotherapy or the same doses. Maybe they could be tapered off, but there are patients that need lifelong treatment. And that is true with opioid use disorder as well. I have experienced, again, at the health department, part of the reason we set the program up was that we were trying to provide care for patients who were indigent in Howard County, did not have access to good care. And what we found in setting it up was, number one, a lot of the providers in the community at the time, and this was probably 5 or 6 years ago, first of all, were cash based. So if you didn't have the cash, you couldn't get the treatment you needed. But one of the big programs for referral was really a long-term detox. Patients were started on buprenorphine and then they were tapered over a 6-month period. So everyone had to be off in 6 months. And again, that is not the evidence-based treatment at this point. So duration is really important. And then I think it's really important to emphasize to patients and to family that they will respond to treatment and they can lead productive lives, but it takes time and it takes work. So I had mentioned person-first language, and I imagine a lot of you probably know what that is, but just to make sure we're all on the same page, this is again from the National Institute of Drug Abuse, and they define person-first language as maintains the integrity of individuals as whole human beings by removing language that equates a person to their condition or has negative connotations. So it's using a neutral tone, it's distinguishing the person from his or her diagnosis. And I, like probably a lot of people out there, have been watching more TV series, streaming series than I was before COVID. And one of the series that I had been meaning to watch for a while but hadn't started was Atypical. And if you haven't seen this series, it's on Netflix. It's a cute show. They're relatively short episodes, and it's about a family, a son who's diagnosed with autism spectrum disorder, and his mom and his dad and his sister, and how they all interact and how they interact with their everyday lives, other people in their lives. And so there was a great scene right when I first started preparing this where the father was feeling a lot of shame and stigma in having a son diagnosed with autism spectrum disorder. And the mother was attending a regular support group, and she had suggested that the father come with her for one of the meetings. So they went together, and the group asked the father to stand up and talk a little bit. And so he introduced himself, and he started talking about his autistic son. And the group jumped on him in the episode and said, wait a second, not an autistic son, you have a son diagnosed with autism spectrum disorder. And I thought that was a great example of how person-first language had moved into the mainstream and the media, and how we can really introduce and fight stigma through good programs like this. So talk a little bit about this person first and language to use and avoid. And again, some of those terms that all of us have heard: addict, user, substance abuser, junkie, alcoholic, drunk, even substance dependent. So I have to admit, I have been guilty of using substance dependence in the past. If you're familiar with the DSM-4, in the DSM-4, there were actually diagnostic criteria for substance dependence and substance abuse. But those were rolled into one: substance use disorder, or the specific opioid use disorder, alcohol use disorder. So we want to use person-first language person with opioid use disorder, person with opioid addiction, patient. And these are all examples of how language can show that the person has a medical problem. They aren't the problem. It's staying away from the
Dr. DePaula, I'm not sure if you can hear me, but I just lost audio on my end, and I'm getting some messages in the chat as well.
Can you hear me?
Yes, that's better. Thank you.
Me?
Try one more time, because it cut out a little bit there.
Can you hear me now?
Yes, that's perfect. Thank you.
Not sure what happened. Something with the headphones. Sorry. Abuse. So abuse can be used, you hear it used in a couple of different ways. So you may hear people talk about abuse of drugs or abuse of prescription medications. And either way, abuse again has that negative connotation. So with illicit drugs, we really don't want to see illicit drugs used. There wouldn't be a medical purpose for them. So we can just say use of illicit drugs. For prescription medications, it would be misuse or use other than prescribed. What language should be used for a person with co-occurring disorders? So that's good. So it may be a patient with comorbidity, a patient with dual diagnosis, a patient with alcohol use disorder and opioid use disorder. Those are all different terms that we can use. And I'll go back and make sure that I get questions as I go too, but if I see questions pop up, I'll try to address them. So next term to avoid is clean and dirty. And I saw people say all, and I saw at least one person specifically say clean and dirty as terms that they've heard. And clearly, we want to use accurate terminology that's consistent with a medical disorder, and clean and dirty are not consistent with medical disorders. So we hear these used often, or I hear them used often, particularly in relationship to toxicology, urine toxicology screen. So it was a dirty screen, it was a clean screen. And a more appropriate alternative, less stigmatizing, would be a urine screen was positive or negative. So it was positive for buprenorphine. If the patient was on buprenorphine, we'd be looking for that. And it would be negative for illicit substances or substances of abuse or alcohol, whatever we know the specific test would be testing for. When we're talking about people, again, people are not clean or dirty. They're either a person who's in remission, a person's in recovery, as somebody had already suggested, a person abstinent from drugs or alcohol, or a person who uses drugs or alcohol. Now, these are moving all to references with medication. So methadone clinic. Some have suggested that we should probably move away from the term methadone clinic. And with methadone clinic, really what we're referring to are opioid treatment programs, licensed opioid treatment programs. So that would be accurate terminology. And the truth of the matter is that opioid treatment programs generally offer counseling, non-pharmacologic therapy. They may offer methadone, buprenorphine, naltrexone. So they're not just the methadone clinic. So it's a more accurate and appropriate term to call them opioid treatment programs. Another area that I have to admit that I was guilty of myself years ago would be opioid substitution or opioid replacement therapy. These used to be terms that were considered medically appropriate terms to refer to opioid agonist therapy. So again, buprenorphine or methadone. But we really want to stay away from the misconception that medications are a substitute for another drug or addiction. So they're not the accurate terms. Again, opioid agonist therapy, if we're referring specifically to buprenorphine or methadone, evidence-based medication, or just plain pharmacotherapy for opioid use disorder are all fine ways to refer. And then probably the one that I'm going to say is a little bit controversial is medication-assisted treatment. I think that we all have heard and still hear, Matt, and it is a easy way to lump naltrexone and buprenorphine and methadone all together, but the assisted treatment part of it really undervalues the role of medication, and it sets treatment apart so that it's different than other medical disorders. So again, it's just medication to treat or pharmacotherapy for opioid use disorder. So I promised resources, and here are two great websites for resources. The first is actually one that I actually just learned about myself in the last few months. It's been around a while, but not notably or not to my knowledge. So the Maryland Department of Health has a website that's called Before It's Too Late. And it's a great website. It's not just focused on stigma. There are a lot of different resources, but they have a section on stigma. They have a handout called Words Matter, which go over a lot of what I just went over, although I use different sources, so they're not exactly the same, but a great resource if you want to share with patients or colleagues. And then they also have some terrific PSAs. So if you want to show videos or just give the links to the videos for your patients or for their family, they really do a nice job in trying to address stigma. So that's one source. Then another highly recommended source is Providers Clinical Support System, or PCSS. And they have a big focus on opioids, but they also focus on other types of substance use disorders. And they have a continuing education program called Stigma and Opioid Use Disorder. And we overlap I took a look at their presentation. We overlap in some aspects, but they have a lot of additional and different information from what I presented as well. So if you want another continuing education program, that's a great resource. And then they also have some sort of PSAs, but they're from the medical professionals' perspective. So if you'd like to see medical professionals addressing stigma and addiction, that's a great resource. There are some societal efforts to address stigma. There's that campaign for equality and parity in insurance coverage, which is really important. There's been a big push to move away from and reduce criminal penalties for people who use drugs. I think a lot of the emphasis has been around cannabis, marijuana, but there is movement across the board, and so we should really support this type of legislation, especially where there's promotion for treatment in the judicial system and the movement towards this is a medical disorder that needs to be managed. And then probably, I wouldn't say nearest and dearest, but to me a super important area is regulation around medications to treat opioid use disorder. And there has been some movement. You may have heard that the data waiver, which is required to prescribe buprenorphine, there was a little chip at that, and so now there's a change where providers can treat up to 30 patients, physicians specifically, can treat up to 30 patients without being data waivered in certain situations. That's new. They're still working on regs, etc. around that, so that's hot off the presses, but it's an example how they're making changes. I just want to make the point, if you haven't really thought about it, buprenorphine and methadone are both medications that can be prescribed to manage pain. And you do not have to be in a licensed OTP. You do not have to be data waivered like you would if you were prescribing them or treating patients with opioid use disorder with those medications. So if you're managing for pain, you have to have a CDS and a DEA, but then you can prescribe for pain. So there's still really disparity in managing, and we've put up a lot of barriers to treatment that are stigma related. Again, these patients can't take care of themselves. They're dangerous. So now we're going to move to a quick little case, and I will tell you honestly, I did make this case up, but it's actually based on what I frequently hear with pharmacy students. So we've been running what we call a fishbowl, which is where the pharmacists work together, the pharmacy students work together as one pharmacist, and they role play managing patients. And one of the scenarios is somebody comes in to have a prescription filled for an opioid, and how you manage that patient, and whether, if you have concerns about the prescription and risk for diversion, etc. And I frequently hear this type of statement. So you're working in a clinic and you overhear, he's a drug addict who always has dirty urine. Suboxone's a substitution of one addiction for another. Why can't he just stop using? So what can we use in this? What can we do in this situation, or what can I do when I work with students? So again, modeling that person first centered language and empathy. Patients get better. They are diagnosed with, it's an individual diagnosed with opioid use disorder. We manage with evidence-based pharmacotherapy. We're not substituting one medication for another or one disease for another. So we're emphasizing that chronic disease model. We're using evidence-based treatment and language associated with it. We're suggesting, or not just suggesting, stating that medication and other treatment is effective. It's important that we routinely screen for substance use disorder. And so it's good that they have that fishbowl where they talk about how to manage patients that come in with prescriptions for opioid use disorder, or for opioids, especially if there's a concern about the prescription. And the more that we do that routinely, that can really make a big difference. When we do something every day, it becomes habit for us, routine for us. And by making it a routine for us, it's apparent to the patient this is something we're doing all the time. And then again, prescribing evidence-based medication and sharing resources. So in conclusion, opioid use disorder addiction is a chronic medical disease. Using medical person-first terminology can improve patient outcomes by reducing stigma, but I think we really need additional evidence-based research on how to effectively combat and improve outcomes. We have some methods, but we need more. So I wanted to end. We'll have an opportunity to ask questions, but I also just wanted to see if anybody was willing to share. I talked a little bit about some of my experiences with stigma. Would anybody be willing to share experiences that you may have had and how you've addressed them? And if you wouldn't mind just putting it into the chat, and I'll look and see in the meantime what questions I've missed that I might want to address. But if anybody's willing to share, that would be great. If not, I'll give you an example, but I'd love to hear what some other people have come across. Okay. Don't think I missed any big questions. All right. So in the
one moment. Thank you. I'm typing.
Okay. Or you can just unmute and tell us.
I got it. Why is buprenorphine considered an opiate by some and an opiate blocker by others?
Okay, that's a great question. So buprenorphine is a partial opioid agonist. So in essence, depending on the situation, it's both. And that's why it's considered, for some, a blocker, and for others, an agonist. So I'll give you the example. When individuals do not have opioids in their system at all, buprenorphine has some agonist effect. It just doesn't have a full agonist effect. So some opioid, I guess, is better than no opioid. And so you have that opioid benefit, and it can help with pain as well as management of opioid use disorder. However, it is an opioid. It is a partial opioid, though. It doesn't have full opioid effect. It's a partial agonist.
Not to sound too technical, but you're from the technical end of it.
Right?
What molecular feature makes something an opiate, and why does buprenorphine not fit that?
So buprenorphine, there as a chemical class, their chemical structure falls into the opioid structure, and opioids refer to both chemically synthesized and natural chemical entities, but they all have a similar structure, chemical structure, if that makes sense. And they work on we have receptors throughout our body, opioid receptors, and they bind to those receptors and produce a chemical reaction in our body, release of neurotransmitters, chemicals, etc. And so buprenorphine binds to those same receptors that methadone binds to, but in situations where somebody is dependent on a full opioid, buprenorphine has really strong binding capacity. It kicks off the full opioid. And so if they're dependent on them, that can produce withdrawal because, again, buprenorphine works it works not as well as a full opioid. It works as a sort of opioid. So when there's no opioid around, it produces some effect, that partial effect. But when there's full opioid around, it doesn't work as well. And I used to have a really good example of this. I'm trying to think what my example was. I can't think of it now, but if you can understand, it's only a partial worker. So if a partial worker is better than no worker, but if you have a full worker and you take the full worker out and you put the partial worker in, you don't get as much done. That's kind of a very simplified example, but does that clarify?
Can you separate the word opioid from the word opiate?
Yes. So opiates, heroin is an example of an opiate. It comes from a natural source where opioids are synthesized in the lab. They were chemically, we do a great job when we produce, and let me say this, opioids include all sources. So they include chemically synthesized and opiates. Opiates refer specifically to natural source for the product. So poppy seeds, for instance. But we do a really great job looking at plants that can be used to treat things, and people use plants for zillions of years, and then breaking the plants down into the chemical entities that might be producing those effects, and then synthesizing something that's chemically, structurally similar to produce those effects. So opioids include
can be included in the opioid group.
What's that?
If everything could fit into the opioid group because it's so broad,
right?
Where does buprenorphine fit?
Buprenorphine is a chemically synthesized opioid. So it doesn't come from a plant. It's something that we produced in the lab.
I have one colleague where I'm discussing specifically that word opiate, and I wanted to know if buprenorphine counts as an opiate or
it's an opioid. It's an opioid. Yeah. So opiates are opioids, but not all opioids are opiates.
Okay.
And it has to do with their chemical compounds. It's just easier to say opioids and then you got them all.
I'm sorry. Does buprenorphine do anything to release everything that makes people feel good?
Yes. It does. It helps to, it works. Again, it works like methadone, it works like oxycodone, it just doesn't produce as great of an effect. So it does something very similar and works on the same neurotransmitters.
Thank you.
Sure. I see somebody else has a question. In your opinion, what is the best treatment for someone whose primary substance use is crack cocaine? As treatment history has taught us, it isn't physically addictive drug like opioid or alcohol. What's your best treatment approach? Great question, and I do not have a magic answer for that. I will tell you that most of the studies with pharmacotherapy really don't demonstrate great results in managing crack or cocaine, so cocaine in general. So we don't really have evidence-based medications the same way we do for opioid use disorder or for alcohol use disorder. But a lot of the non-pharmacologic, the counseling and the different therapies that we use for substance use disorders in general obviously are effective for cocaine use disorder. So there clearly are treatments, and they're doing a lot to assess around management for not only cocaine, but you may be aware that there is really a pretty significant issue now with stimulant use disorder as well. And so cocaine is a stimulant, and we know that we really don't have great treatments. Methamphetamine, for instance, we don't really have great management from a pharmacotherapy perspective for those type of use disorders, but our tried and true treatments are still really beneficial. All right, so I have another question. When a person reaches out for help and support in the medical field, first assessment is that the person's an addict without assessing the mental health conditions. Why does the medical field not acknowledge that co-occurring disorders tend to mimic and mask each other, thus leaving the person who reach out vulnerable and because of stigma keep on using? That is absolutely great question. And there has been a big push for change in philosophy and assessment for patients with comorbidity. You cannot treat one disorder. You have to treat the entire patient. So if a patient has opioid use disorder and you just want to focus on their depression and not deal with the opioid use disorder, or you just want to manage the opioid use disorder and you're not going to treat the depression until the opioid use disorder is better managed, patients are not going to succeed. All the data that we have with comorbidities suggests that you really have to deal with all of the psychiatric disorders that the individual is experiencing. And you don't want to use punishment of one disorder as motivator for another. For instance, you are not going to be prescribed buprenorphine unless you take your antidepressant, or vice versa. You need to use the best evidence-based treatments at the same time in parallel. So it is an area that we're really still working on, but I'm glad you brought it up because it's very important.
Could I ask how many of the patients taking buprenorphine have psychological or psychiatric problems that need medicine?
I don't have a magic percentage off the top of my head. I'm trying to think of what I've seen statistically. It is very common for there to be comorbidity with substance use disorders in general and other disorders, depression, anxiety. And I feel like in general, I've seen around 65-75% comorbidity when you look at combinations of disorders, but I cannot think specifically for patients managed with buprenorphine. But you do need to consider it more likely than not and look at what symptoms an individual is experiencing, whether it's secondary, because you can have symptoms that are secondary, obviously, to substance use. You can have individuals who have depression or anxiety that are either induced by substances or part of withdrawal. And you can have two comorbid disorders. And so you really just have to look at the overall symptoms and, again, manage as a whole.
How often did the buprenorphine people get an attention deficit disorder as well, or
I actually, that is a common comorbidity, not just with patients that have opioid use disorder, but you see it a lot with substance use disorder in general. It is one of the common comorbidities, and it is an area where stigma can play a role in how people decide to treat. And there is a lot of data that suggests that patients can be managed. Not every patient should be, but patients can be managed with stimulants and have a comorbid substance use disorder. So again, you have to really look at what's going to be the best treatment for that patient and not make just kind of knee-jerk decisions for everybody. And I personally have a couple of patients in my clinic who have substance use disorders and who are being managed very successfully with stimulants because of their ADHD. So
Thank you.
it happens.
Thank you very
Sure,
much.
sure.
Because I'm in a position to say that I think that most of the buprenorphine patients do have some psychological problem to match.
Trauma is also very common in this patient population. I think a lot of times when people think about trauma, they think of military related trauma, but there's so much civilian trauma. Again, the patients that I manage are often native Baltimore City, have grown up with gang violence, have grown up with family members with substance use disorders. And so that's a common comorbidity that I'm sure you see a lot as well.
I frankly think that that's a large part of how these people got into it in the first place.
Absolutely.
Thank you. I
Sure.
love hearing that. I do.
All right. Well, if there aren't other questions, I don't want to keep people too long. I see I'm running 5 minutes over. Sorry about that. But I thank you all for your great questions and attention. And I look forward to potentially future discussions.
Thank you so much for presenting, Dr. DePaula. I'm already seeing some great feedback in the chat. So thank you so much. And thank you everyone for joining us today.
Thank you.
All right. Everyone have a good day. Bye-bye.
Bye-bye.
Didn't even have a date on the back.
Thanks, everyone. Bye-bye.
Bye-bye.